Last week, we defined ethics, defined bioethics, and then we talked about the development of ethics with the medieval church and the Enlightenment period. We ended our long lectures last week by talking about 6 different ethical theories. This week, we're really going to focus in on the subcategory of ethics known as bioethics, which is the focus of this course. Do not worry, the ethical theories that we talked about last week will be applicable in bioethics. However, I think understanding the history of bioethics, which really began in the 1960s, will help us as we progress through this course. While the study of ethics in general dates back to the ancient Greek philosophers such as Socrates, Plato, Aristotle, bioethics and ethics related to healthcare, biology, and life sciences didn't really begin to emerge until the 1960s and 1970s. Healthcare in the 1960s and 70s was very different than healthcare today. Healthcare was very paternalistic. The medical system had a strict hierarchy with physicians at the top of the hierarchy. The role of the nurse was very different than it is today. Nurses in that time were very task-oriented. They were an assistant to the physician, and they had more of a caregiver role and task role than really being a profession. The professions of physician's assistants and nurse practitioners did not come into existence until the mid to late 1960s. In the 1960s, you really didn't hear concepts about the patient experience. Healthcare was grounded in what the physician said, and patients didn't really question this. And we do see some of this coming through still in our older generations, those individuals that follow whatever the physician says, no matter what. My dad is one of those individuals. I have often said that if my dad's physician told him that he needed to stand on his head 20 minutes a day for good health, that my dad would stand on his head 20 minutes a day because the doctor told him. At this time in the 1960s, women really didn't have much of say in healthcare. And on May 4th, 1969, a group of women from Boston met at a workshop called Women and Their Bodies. And the idea surrounding this workshop was that these women wanted to get a better understanding of women's health and women's health from the standpoint of women who were living it, not just women's health from what their male physician providers were sharing with them. And while these women entered this workshop as activists who were just trying to make sense of the muddle of medical information surrounding women's health, they ended up making history. And they ended up making history through a book they published called Our Bodies, Ourselves. This book is a very famous, well-known book. It sold millions of copies in 17 languages and Braille. And really, what these women were pushing for was to have the patient consciousness, the patient voice heard. And some other events that were occurring around this time period also brought forth this need of being able to hear the voice of the individual. This was the time period of the Vietnam War, which generated a large amount of protest, political unrest. And also, at this same time period, was the civil rights movement. Again, a lot of protests against these established order and authorities that no one had really questioned in the past. And arguably, for one of the first times on a large scale, individuals and groups with power, those higher up in the hierarchy, became pressured to negotiate with and listen to those individuals and groups who had less power. And so this demand for equality and individual rights became very intensified, as you saw through the civil rights movement, through the Vietnam War era. And medicine and healthcare were not exempt from that. Individual rights, patient autonomy started to become important. People started to question, why don't I have a say? I'm listening to this doctor, but what about my thoughts? What about my rights? What about my beliefs? And so this commitment to patient autonomy and rejection of medical paternalism became the new frontier of medicine. So if you think about the way medicine is today, if you've ever or recently been a patient at a medical facility, you probably got a follow-up survey about the patient experience. There's now this focus on the patient experience. The patient's bill of rights is a term we're hearing more frequently. Patient autonomy, making the patient an active member of the healthcare team. And this time period, the 1960s and 70s, is where a lot of what we are seeing today in medicine, this is where it was birthed from. This is the foundation. So I really think it's important to understand that the healthcare system you are looking at today was not the system of the 60s and 70s. And this is the birth of bioethics. So on the last slide, I mentioned this new frontier of medicine that was being led forward with a focus on autonomy and rejection of medical paternalism. So what was going on during this new frontier of medicine? Well, we're going to take a look here. And this is going to stretch a little before the 60s and 70s to a little bit after the 60s and 70s, but we're going to focus on three main areas: technologies and treatments, then specifically reproductive technology, and then scientific research. So this was a booming time for new technologies. The kidney dialysis machine was developed in 1945. The dialysis shunt was developed in 1962. Heart-lung machines, which would help breathe artificially for a person. So you kind of think of like the ventilators of today. Those were developed in 1953. And organ transplantation began in 1964. And while today we think of these technologies as commonplace and everyday practice and things that we're aware of, you might know somebody on dialysis. You might know someone who's had an organ transplant, or maybe you yourself are an organ donor. These are things that we accept as everyday practice, but in this time period, they were very new. And they brought forth these questions. And these questions that they brought forth are some of the questions that we have to answer in bioethics. So, with these new technologies and treatments, are we actually helping patients, or are we causing them more harm than good? Is modern medicine selling a false hope? I mean, in the beginning, when you read about organ transplant and the short amount of time people lived after a transplant, there was questions of, are we giving them this false hope of recovery? And everything we put them through for this transplant to end up having a rejection and die in 2 weeks, is it worth it? And then, when does life end? If we're putting someone on a heart-lung machine, when do we consider them alive or that their life has ended? Next, we'll talk about advances in reproductive technology. Many of these advances are things that you have heard about. Amniocentesis, very commonly done today, especially in mothers of older gestational age. Amniocentesis, in the 1950s, we first started using those to diagnose genetic diseases. In vitro fertilization began in the late 1970s, as well as surrogacy. And in 1962, the first animal clone occurred. And so this really brought forth some other questions. What about these non-viable pregnancies? If an amniocentesis is done and this baby is found to have a genetic disease that is not compatible with life, do we carry the baby to term? Should the baby be terminated? What about the risk of the mother? How do we compare the value of the mother's life to the life of the fetus? And then along these same lines, when does life start? And then how do we define a human? Another frontier in medicine was scientific research. And scientific research at this time period often involved non-consensual, non-therapeutic experimentation on vulnerable populations. And when I think about the scientific research of this time period, I immediately think of the Tuskegee studies, which these were studies that were done on African American men with syphilis, and these men were not provided with penicillin as a treatment. And there's actually an excellent movie on this called Miss Evers' Boys. Great movie about the Tuskegee experimentation and the impact that this had on this vulnerable population of individuals that were being denied a treatment that was known to be effective for the sake of research. And so this led to some very important questions regarding research on human subjects. What rights should research participants have? How much knowledge should they have about what's going on? How do we get consent from them? Should we get consent from them? What is informed consent? And then what are the responsibilities of the researchers? What standards do we need to hold these researchers to? So, while this new frontier of medicine brought forth many advances that we are used to today and that we accept as common practice, it also brought forth some very important ethical questions that we are still trying to answer and grapple with today. While these new frontiers of medicine brought forth some ethical issues, there were also some major court decisions that were made during this time period that set some important groundwork for how society responded to some of these ethical questions, as well as how society was responding to increased patient autonomy. Court decisions at the beginning of life were really focused on the individual's right to privacy in matters of sexuality and human planning. So in 1965, Griswold v. Connecticut established the right to privacy for women's possession of birth control. And it was found that this right to privacy was owed to women within the Due Process Clause of the 14th Amendment. This court decision would then further be extended to non-married couples in 1972, also allowing them the right to privacy for the possession of birth control. I think we're all very familiar with Roe v. Wade in 1973, which established the right to abortion. And one of the things that we will look at in this course is the ethics of then the recent overturning of Roe v. Wade. Just like there were court decisions regarding the beginning of life, there were also court decisions that came forth about the end of life, and again focused on autonomy, and this time the rights of the individual to make end-of-life decisions. We are probably all very familiar with the idea of a living will. Some of us may have a living will, your parents may have a living will, and a living will basically talks about what are your wishes for healthcare directives when you're no longer able to verbalize those yourselves. Well, the living will wasn't proposed until 1968. And then in 1980, Satz v. Perlmutter established a competent patient constitutionally protected privacy, liberty, and their autonomy in interest of removing life-sustaining treatment. So again, the patient is having a greater say in their ability to voice their own wishes and opinions about receiving or not receiving life-sustaining treatment. So we just talked about the new frontier of medicine and what that brought forth. And we talked about some of these very important court decisions regarding patient autonomy and patient rights at the beginning of life and at the end of life. And all of these situations, these new advances, they brought forth unprecedented questions of professional values, practice, and relationships. However, beyond that, this new frontier of medicine began to test the established social limits. There were new questions that had to be answered, and I have some of these questions listed on this slide. We now had to consider what new ground rules would govern this new biology, these new liberties and autonomy that patients were receiving, and this new research that was occurring. How and where should and would we draw permissible limits? How do we know what a permissible limit is? And who's going to make the rules that are going to govern this new frontier of medicine? And how are they going to make these rules? And this is really going to lead us into the people that we call the pioneers of bioethics. So the pioneers of bioethics we're going to talk about as the theologians and the philosophers. And how you viewed the relationship between what is good and God is really the foundation of how you view ethics. Whether ethics comes from the foundation of religion and theology, or whether ethics comes from the foundation of philosophy. So it makes sense that the two groups of pioneers that would be answering these new bioethical questions would fall under two categories, the theologians and the philosophers. First, we're going to briefly discuss the theologians. The theologians were students of the nature of God and religious truth. And these individuals took an interest in the implications of this new frontier of medicine and how that this could be applied to understand fundamental matters such as human nature, human destiny, the value of life, and the meaning of illness and suffering. However, as we discussed in the first PowerPoint as well, not everyone is going to agree on the answers to these questions, even amongst theologians. So there were some fundamental differences that occurred between the theologians. There was no one single religious, quote, voice at the beginning of bioethics. There was no one single religious viewpoint answer to these questions. And this was because the different theologians came from different theological traditions, different backgrounds. And what this shows us today is the debates that still occur between those who follow religious orthodoxy and religious progressivism. So the other group of pioneers that we're going to look at are the philosophers. And the philosophers were students of the ancient pursuit of wisdom and enlightenment about how you should best live. And the philosophers' contribution to bioethics was that they often staffed the institutions that helped to establish bioethics as an acceptable interdisciplinary field dealing with ethical, social, and legal aspects of the advances in medicine and medical science. So the philosophers really set the stage for the social policy of bioethics from the 1970s forward. However, they would not have been able to make these advances if the philosophers and the theologians did not bridge their differences. So now we're going to kind of look at what these two pioneers of bioethics agreed upon and what some of their differences were. So you might be thinking that the theologians and the philosophers seemed very similar. And a lot of times I have found that these two groups, their names have been used interchangeably. But there are some very important differences that I wanted to bring to light here. And I really like how Vincent Berry describes the difference between theologians and philosophers. And he does this on page 65 of his textbook, Bioethics in a Cultural Context. And what Berry said is, it has been said that philosophy is like standing in a dark room and looking for a black cat. Theology, on the other hand, is like standing in a dark room, looking for a black cat and shouting, "Found it." And when you think about the foundation of theology versus philosophy, this sentence starts to make sense. Theologians place their trust in faith and an overarching universal truth, whereas philosophers place their trust in reason and rational demonstration. For theologians, the final truth has been found. They know their final truth, that universal truth that comes from faith. However, the philosophers are still searching for that final truth. For the theologians, the source of authority is a divine being greater than them. And for philosophers, the source of authority is secular and human-based. So therefore, the philosopher is in the room looking for the black cat, never really sure if he's found it, because he's focused completely on reason and rationality. And can you truly see the cat in the dark? And you're looking and looking and looking for that cat. Where on the other hand, the theologian has the truth about the cat. They have found an item in that room, and they have the faith that that item they found is the cat. So just some basic understandings of the difference between the grounding of theologians and philosophers. Going back a few slides, if you remember, the philosophers and theologians were the pioneers that were going to respond to the testing of the established social limits of the time. They were the individuals that were going to determine the ground rules to govern this new biology, new individual liberties, and new research, and also determine where permissible limits should be drawn. So these two very different groups of individuals met regularly at the Smithsonian's Belmont Conference Center. And in February of 1976, they had an intensive 4 days of deliberation. And while they did not come from common belief systems, as we saw on the previous slide, they had some common interests and viewpoints. And these commonalities were what would allow them to bridge their differences and come up with some very important answers as the foundation of bioethics. So, what did they have in common? They shared views, interests, and purposes regarding healthcare. They believed that health was the ultimate goal of medicine, and that the purpose of the medical sciences was to benefit and use life. So the purpose was to advance human life. Therefore, about humans, both groups believed that humans have inherent dignity and worth. They also understood that to respond to these established social limits and to provide any level of indication about answering these important questions, they had to have support of the medical professionals. They also shared a state of mind influenced by the Enlightenment. Both groups came forth with this desire to balance utility, which is the greater good for all, and autonomy, which was individual preferences. They both had a sense of faith and rationality. They were both very rational groups. And they both had a background of inheritance of a national religious identity that tended to stem from Judeo-Christian Enlightenment traditions. So this was the groundwork, the common agreements on which bioethics would be grounded. No pun intended. So our last tidbit of our history lesson is the Jeffersonian Compromise. The original Jeffersonian Compromise became part of the United States Constitution, and this was the idea of separation of church and state, that religious liberties of individuals would be protected. However, they would be separated from the church and state and law, and anything that would be part of state and law needed to go through the scrutiny of common sense and being reasonable, not just grounded in religion. The founders of the modern-day bioethics realized they, too, needed to come up with some type of compromise, because not only were the pioneers having different point of views, but they wanted to appeal to a broad audience. Their goal was to appeal to not only theologians and philosophers, but also individuals who were conservative and liberal, the orthodox and the progressive, the scientist and the non-scientist, the physician and the patient. So what they ultimately adopted was this idiom or idea that any particular theology or philosophy was inappropriate for shaping policy in a secular pluralistic society. Therefore, they could not just rely on one theology or one philosophy to ground bioethics in. Bioethics needed to be grounded in publicly acceptable reasons that would provide desired conceptual frameworks that would offer a universal appeal. So this allowed them to maintain neutrality on religious, theological, and philosophical grounds. However, there has been statements made in the 21st century that this Jeffersonian Compromise is now open to renegotiation, and that the trade-offs to produce neutrality may have in themselves become a specific standpoint. So while you're trying to be neutral between these stances, did your neutrality create a third stance? And that's just something to consider as we go through this course.